Welcome to the latest webinar with Hired Power. This webinar is titled The Hidden Epidemic, and we are hoping to educate you on fentanyl and synthetic opioids. Today, I am very excited that we have two phenomenal speakers. First, we have Deidre Fitzpatrick, who is a nurse. She is the COO at Hired Power, and she has worked in the field of nursing for many, many years, specifically in the field of addiction and behavioral health. And she most recently was the nurse manager of a 36-bed locked psychiatric unit, a 31-bed chemical dependency unit, and an outpatient chemical dependency program for a hospital. So she definitely has a lot of knowledge around this subject matter, and we're really excited to hear all of her expertise from the nursing standpoint and from the standpoint of working with Hired Power. And then we also have here Dr. Mario, who is an addiction medicine specialist. He is board certified in both family medicine and addiction medicine. He is from the Orange County area and still lives in California. And today he holds a lot of very impressive positions, everything from being a passionate advocate for improving access for care for people around the country. He's a certified medical review officer. He works on a national level with organizations like CSAM and ASAM. I hope I said those right. And he serves as the National Medical Director for Substance Use Disorders and leads the National Center for Innovation on Social Detriments of Health and Molina Healthcare. So they are both highly qualified, and I'm very excited to see what they have today. So without further ado, let's get this presentation started. And Dr. Mario, floor is yours.
Great. Thank you so much. I'm really happy to see as well that the number of folks that are here from that harm reduction side and prevention. Thank you so much for what you do. It's so important. So we're gonna take a little bit of a tour around overdoses and discuss synthetic opioids. First of all, we can take any lens. You can kind of put a little dimension to any view of this topic, right? So I promise not to geek out too much on you on the medical side. I want to balance it out with maybe the more important parts of it. It's also social as well as political even. There's some aspects of how we approach things that sometimes make things more difficult. And so we definitely want to understand the evolution of the opioid epidemic, and there's different ways to view it. I'll offer you kind of a combination of a couple of ways, going historically, kind of where we came from, and then also where we're at today, as well as discussing why is it that we are in a peak? Why is it now that there have been more overdoses than ever in the history of us, keeping track of it? And then also that discussion that I told you was so important around harm reduction and understanding some of the evidence-based treatments for opioid use disorder. We're not going to spend too much time. We're going to leave some time for questions, and then I'll be starting it off. And then after this, Deidre will pick it up from there. I don't have anything to disclose. I don't get paid by pharmaceutical companies. I don't have any special contracts or anything like that. I mean, I still see patients. I see them at FQHCs, which are federally qualified health centers. That means I see the folks that are kind of the poorest and oftentimes the most marginalized. I do see them for addiction medicine related issues. And then from the administrative side, as mentioned, I serve as the medical director, the national medical director for a health plan that serves primarily the Medicaid population, like 90%. So complex patient population. And I have the privilege to kind of serve them in various ways. So let's talk a little bit about statistics here. I mentioned to you that most recently we're at a peak at about 93,000 overdoses, and so just before this we had already been on climbing. We thought we had a little bit of a drop that was going to stay, but it didn't, and so it's continuing to go up. And that's not because of more prescriptions being written for opioids. And primarily it is being driven by opioids. We know that addiction in general and prescription drug issues were very expensive. And that the estimated cost of addiction in general is getting towards $1 trillion. So I like to tell people that in case you don't care. Everyone on this call will care, but sometimes I'm talking to folks that maybe need a little nudging. They may not care from the standpoint, from the heart or from the medical science side. Then I appeal to their wallet and saying, the biggest payer for all this is actually public. So it's coming from taxpayer dollars. So if you don't care from the other side, then care about it from that side. And maybe the most telling and significant statistic on this page is really the last one, is that though we have a large number of people that have some type of substance use disorder of some kind, that only about 11% are actually receiving professional care at some point. Now, that would be unheard of if I were talking about diabetes, another chronic illness. And we certainly wouldn't stand for it if it were cancer, right? We'd be marching in the streets. But for some reason, we're not marching in the streets. And there are not too many 5K runs to support your local person on heroin. But there should be, right? There should be some of those things. So the stats are pointing in the direction of getting worse, not better. Let's go to the next slide. And like I mentioned before, it's been a kind of a steady rise. And I would have to adjust this graph one more, a couple more lines to get to where we're at now, because we continue to increase upwards of that 93,000. Next slide. The important thing to take away from this chart here is that even though opioids is still kind of front and center, the front page, the sexy one, it's not the whole picture. So if we look at the blue line, which is the one that has the slope of the curve going almost straight up and down, and on top says synthetic opioids other than methadone. So this, we're talking about synthetic opioids that, ones that we produce, either in a lab, a clandestine lab, or in a legitimate lab. And then we're also excluding from that things that are like, from treatment centers like methadone, or even methadone that's not from treatment centers. And if that the drugs that are involved in these overdoses, you can see it's just this almost straight up and down. However, if you also look a little bit below that and you look at cocaine and methamphetamine, I want you to look at the slope of those curves. The slope of those curves are going higher. So one of the things that we're going to talk about is the concept of the different waves of opioid use and how we are now being affected by opioids, and maybe even some of the implications of some of the ways that we've chosen to deal with it. So we are not done with stimulant use, and so that's going to be one of the most important takeaways here before we're done. Next slide. Now, I would be incomplete if I didn't include something about the coronavirus, right? We had COVID-19 related problems. Right from the get-go, we started seeing people with higher rates of reporting of depression and anxiety. This is primarily from the group that did not have a known diagnosis of depression and anxiety. So even though we know that there were exacerbations, that people were kind of coming, at de novo, they're having some of these side effects, primarily from things like social isolation, all the new rules. The fact that people also didn't have an opportunity to go in and engage with the healthcare system. And so it left a lot of people doing their own things, sometimes self-medicating, loneliness, not having the support system that all of us that are involved in treatment of substance use or affected by substance use in some way. Maybe you love somebody that has a substance use disorder. You know how important community is, right? Not just in the mutual support, like 12-step type thing, but just community as a general sense. It is so important, as important as the medications and all the other stuff. Though, that certainly took its toll. Financial stressors, people getting, evicted or, losing their job. All those things created triggers for a lot of people that maybe were coasting and doing okay with relapse prevention type of tools that they might have gained, but then, fell to the side after they were increasing the stressors. Now, could you pick a more damaging, catastrophic collision than COVID-19 and the opioid epidemic? I mean, so this is part of what we'll be discussing. So certainly everything worsened. However, we were already having a slope of the curve that I showed you already before 2019. So we were already going down this trajectory. This is just kind of like a insult to injury type of situation at this point that we're at. Next slide. And some basic things to kind of get a sense. A lot of people really think when they think about the opioid epidemic, they're thinking about, oh, look, these doctors are, prescribing left and right. And certainly there are some bad players even today that are caught doing those, unethical things. But it's quite the minority at this point. And we've steadily over the last decade, every year has been lower and lower and lower for lots of different reasons. And it's resulted in some good things in terms of decreasing the supply, but it's also resulted in some bad things. And the bad things are, for example, if you have somebody that's dependent on an opioid and you cut off abruptly any sort of access to an opioid without all the rest of the support that they need, they will tend to go to some other substance that's in the opioid family to be able to make the nastiness of withdrawal go away, right? Because when you withdraw, your nervous system doesn't know the difference between dying and whatever it's supposed to be feeling. So you go into a fight or flight type of response. Kind of like if you're chased by a dog, you don't think of, well, what's the pathway that I'm going to take? You just kind of go. And that's what the body does. And the nervous system makes people do. So they might be making great decisions otherwise, but faced with the situation, they may make less than desirable types of things. So a lot of people were basically moved towards heroin is one of the things. But if you think about, who initially gets there, about 21 to 29% of the patients that are prescribed opioids on a chronic basis, right, more than around 90 days, misuse them. Now, misuse could be like, the doctor gave me the Vicodin for my knee pain, but you know what? It helps me sleep at night, so I'm going to take it for sleep too. All right, now we're into this realm of misuse. You weren't supposed to do it for that. Or, hey, it decreases my anxiety level. I'm going to go and work and I'm all stressed out, so I'm going to pop one of these. Again, you weren't told to do it that because that's not the indication for it. And you find yourself eventually with enough exposure that you get dependent and you have a whole separate cascade of problems. Now, dependence is not the same as addiction, right? Not the same thing. Dependence just means that physically there's a consequence to you stopping the exposure of that chemical. And then addiction involves a whole cascade of other things, primarily behaviors that also reinforce that and cause all sorts of things where there's the compulsive seeking of the substance despite negative consequences. And so, of that group that misuses, about 8 to 12% will develop some sort of an opioid use disorder, right? It's kind of this spectrum. And then of that group, only 4 to 6% will use, heroin. Let's go ahead and go to the next slide. So we're going to talk a little bit about, and this will probably be, I think, one of two other like potentially triggering slides. But it's important to know the differences in terms of how even the forms in which we are, it's not just injection use, it's not just snorting, it's not just pills. And it's not, I mean, there's all sorts of different ways that folks are using substances, in particular opioids and opiates. So opiates really means it's the chemical that comes from the poppy. So those are the chemicals that are derived from that, like morphine, for example, right? They're technically morphine, thebaine, codeine. Then most of the other things are either semi-synthetic or synthetic. That means that we produce them in a laboratory. We might derive them from some other aspects, other parts of the chemical, but not from the poppy. And that's kind of the difference between an opiate and an opioid. Go to the next slide. And this is more for you to kind of, you can peruse, you guys can give you guys access to the slides, but we have a long history of actual contact with substances that change our state, right? And opioids aren't, any sort of an exception to that. I mean, whole wars have almost been fought just because of not having access to opium. And in the United States, one of the very first ever racist laws that existed around substances happened because of opiates. When in San Francisco, people that were Chinese were banned from going to opium dens. So you could go if you weren't Chinese, but you couldn't if you were. So there's a lot of history, political, culture, and a lot of other things, right? Even we talk about some substances that are legal, like, Russia has vodka, Mexico has tequila, the Greeks have ouzo. I mean, every country and culture has its intoxicant of some sort. And so it's embedded really in all cultures. And it's neither good or bad, right? We tried that whole thing by putting people in jail with a good and bad type of look. And it's not really that. That's not very helpful, although there can be an aspect of it. There's a dimension, right, that we can view this problem through that lens. Next slide. So we come from a time even where, for kids who were teething, we were giving, opium tincture. So, it's not completely new. Next slide. And when we wanted our little Jimmy to be mommy's little helper, we always had children's morphine. right? And so kids would relax a little bit. We have had moments of exposure, but interestingly enough, these exposures did not necessarily result in overdoses, right? So it's not necessarily the same thing. Even when we start looking at exposure to a substance versus dependence versus addiction versus death from an overdose, they have different dynamics all the way through. Next slide. And so I'll submit to you, there's at least 4 waves. I would argue 5. In that, if we go back to the late 1800s, about 50% of the federal government's budget was actually on taxes for distilled spirits. So it was a substance supported. We were a substance supported country. Half of the Mayflower was filled with beer. And then, cocaine and opium came around, and it forced us to create the concept of a prescription, the concept of a pharmacy board. We didn't have it up until then. And it was because we wanted to regulate it. Some people were getting hurt. Some people wanted to make money off of it. And so there's all these forces involved. So I would actually move the very first wave back then, when it was just the very first 2 chemicals to be written on a prescription pad, were cocaine and opium. And so now, though, when you fast forward, and even though there are other things that affected us at least in American culture, where you can throw in barbiturates and amphetamines for a period of time, 30s, 40s. You can throw in now when I have opioids here, I mean prescription opioids. And I would even toss in a little benzodiazepine to that, some sedative hypnotics, because it did make a difference. Not quite as exciting, not quite as sexy. However, very impactful. We're still dealing with a lot of problems around that. And then we mentioned before that one of the things that we did was we kind of squashed the prescriptions, right? And where did people go to? A lot of folks went to heroin. Cheaper, you get a much faster high. It's still in the opioid type of a family, but much more destructive. And so then when we started kind of controlling a little bit of that, then also came fentanyl. We'll talk a little bit about that in more detail. And fentanyl is a synthetic opioid, many, many times stronger than morphine, like 100 times stronger than morphine, and very dangerous. And some of its derivatives can be up to 1,000 times stronger than morphine, like carfentanil, where it's so dangerous that being off by less than what is the equivalent of around a grain of sand or a grain of what you see here could be actually lethal. That's so, if you think about folks that are handling it or putting it into other chemicals, there's not a big margin of error, and these folks are not doing this in a chemistry lab. And then our 4th wave that we're going to maybe stress here today is just that I mentioned to you about the stimulants and methamphetamine. It's the intertwining now of that with fentanyl. Next slide. So we know that in terms of fentanyl-laced heroin, it's sold as heroin. People aren't necessarily buying fentanyl, although now we do have a contingent of folks that are actually seeking fentanyl. This is relatively new, a little bit more common in the East Coast still than in the West. We'll show you a map of that in a little bit. But people think that they're potentially getting heroin, and fentanyl is 30 to 40 times stronger, by weight. And so it's easier to transport if you're going to do something illicit, if you're a drug dealer, and you can cut up and take something that you might have purchased for $100 and make it into $1,000 by cutting it up and adding a few things, a little talc, a little whatever else. It's a white powder at the end of the day, and then it can be consumed in all sorts of different ways, whether it's pressed pills, whether snorted, whether diluted and then injected. All of those forms can still be used. In addition to some other more creative ways. It is not diverted fentanyl. So if you were wondering if the fentanyl problem was because people were prescribing lots of fentanyl, or they were stealing fentanyl from hospitals, or they were stealing fentanyls from warehouses, not the case. This is usually acetylfentanyl. It's an illicit form, a clandestine type of form of fentanyl. Now, fentanyl by itself, is it good or bad? No, it doesn't have a personality. Sorry. But if you have cancer pain, fentanyl could be your friend. It can help you have some quality of life. So it has its uses. This is a narrow use because of how strong it is. In the ER, if you broke your arm and your bone is sticking straight out, and somebody says, "Hey, we're going to need to pull your arm back and get it, attached and get you ready for surgery. We're going to give you some fentanyl." Probably okay to say, "Yep, no problem," because that's going to help you get through that moment. But not safe for long-term afterwards for lots of different reasons. Next slide. And then I mentioned to you that it's produced kind of clandestine. We also know that most of it comes from China. And then we have the routes of how it gets into the United States, both from above and from below. So Canada and Mexico. We were very used to Mexico. We were not used to Canada so much, but it's very much, being one of those things. So we can no longer only focus on certain borders around what the DEA has to do to try to capture some of it. And a lot of it that's being captured is being tested. And then they're looking at how much even of other like pressed pills or other supply of other drugs have contamination with fentanyl in it. And depending on where you're at, it can be quite high. Next slide. And then if we look at, again, the kind of the process of how it's affected us, it really was a Midwest, Northeastern type of thing initially, right? Whereas in the West, we were pretty comfortable with meth, and we had meth growing out of trees. And so they weren't used to it. We gave that to them, and they were so nice, they gave us the fentanyl. So, in kind of almost in exchange, you can kind of start seeing the overdose pattern rise and increase in certain states. And right now, places like Washington and California, Arizona, Nevada, we're beginning to get more and more and see more and more of that. Next slide. This came out just yesterday. I thought I'd include it. A public safety alert from the DEA, a sharp increase in fake prescription pills containing fentanyl and meth. So some of the folks that you might bump into, again, they're not necessarily looking for fentanyl. However, they might have been looking for MDMA or maybe taking something. I've even had folks that have been using, they thought they were using Xanax, and they were pressed pills that had all sorts of things in it, actually. So there's even from the side of benzodiazepines, lots of different things that can be contained in a pill. Now, if you're somebody that thought you were getting MDMA and therefore were essentially opioid naive, which means your body was not set up to have the tolerance to be able to engage with that chemical in your body, you can be a one and done. Okay. And then now we're beginning to lay the groundwork for why. Not only is it so potent, and not only is that little area of error so narrow from the standpoint of preparing whatever you get, that folks are also not even knowing why they're, in terms of what they're getting. And so the likelihood of overdose can get quite high. Next slide. And this is another look at the overdose rate, but through California. And I kind of mentioned that we're kind of just beginning to get some of this. And so you can look at the United States versus California there on the bottom. The graph's beginning to go up, and it does continue to go up. So the East Coast has a lot of measures from a lot of their systems over there, whether through harm reduction type or health plans or hospital systems, EMS, that they've already kind of stumbled and gone through that we still don't have yet. There's some areas that they might be more sophisticated at because they've been exposed to some of the consequences of it. For example, in some places, and like in West Virginia, there could be situations where in their town they have EMS that gets sent out with a therapist that gets sent out with law enforcement and even a pastor on a call of an overdose. And so they're trying all like multimodal type of approach at addressing some of the things. And then, of course, there've been missteps too. There's all sorts of nonsense that we create as people, right? At one point I saw that there was one of the towns that tried to pass a law saying that if you receive Narcan 3 times, it was a 3 strikes, you're out. You didn't get another time from EMS, which is crazy, right? I mean, can you imagine if I said that about insulin? If you've had diabetic ketoacidosis and have been hospitalized, where you only get insulin a few times, that would never happen. And it comes from this weird stigma that we still have around substances that kills people at the end of the day. But we still have it. We still have the stigma. It's an important thing for us to talk about. Next slide. We do have some intervention. Oops. We do have some interventions around opioid use disorder. That's not necessarily unique to fentanyl. The fentanyl part has an aspect of it that has to do with harm reduction that has even a few added areas. But in general, for opioid use disorder, we do have some evidence-based treatments. And in some cases, medications like buprenorphine. We've had methadone for a long time. And then when you combine those with the rest of the kind of community and therapy and mutual support that you have a chance, and sometimes even contingency management, where we're looking at ways to help people get more engaged and encouraged to change certain behaviors. Those can be very useful to stabilize people. They're not solutions to addiction, but they are approaches for harm reduction. So things like Suboxone or buprenorphine can be life-changing things that you can do for somebody. But again, they're not forever medicines either, in general, although people, will use them as long as they are as useful for them. That keeps them from relapsing. And during the question and answer, people have more specific questions about medication-assisted treatment. We can talk about that. But one thing I'll bring up is that for doctors like myself, who also, are engaged in providing MAT services, for example, is that fentanyl has changed the game some, because fentanyl likes to sit around and go into our fat. And so it, goes and stores there, and then it leaches out slowly. So what would normally be a short-acting opioid in other circumstances, like in an ER, does not act like a short-acting opioid when it's in the body being smoked every day. And so what happens is when we start medicines like buprenorphine, it can cause a side effect called precipitated withdrawal, when people can have a tough time getting on the medicine. And that has been a very significant thing. It's caused us to have to reframe how we even start the medications, using things like micro dosing and for what we call inductions. So, but evidence-based, nevertheless, can be the difference between alive and dead. Okay, it does work. It's also not for everyone, though, and it should always be done kind of in concert with a multimodal approach. Next slide. And I'll talk briefly just about Narcan, and then next about fentanyl strips, just to round this out. And Deidre is going to talk a little bit more in detail. But you should know that if you're somebody that cares about somebody that has an opioid use disorder, or just has opioids in the house, just could be grandma that she's not addicted to anything, but she gets some amount for whatever reason, that it's important to know how to use Narcan and to access it. You don't have to be being treated yourself. California has like a statewide prescription. You can go to any pharmacy and just ask for Narcan, and they'll give it to you. And so it's available to everyone. It's a nasal spray, gets absorbed through the capillaries of the nose. You just a little nasal spray. This is the 4 milligram formulation. Because of fentanyl and its derivatives, we've had to kind of invent an 8 milligram one, because people were needing so many doses of the 4 milligram to reverse them that it was a problem. And of course, once you use the Narcan, it doesn't mean you don't call 911. You still call 911. It doesn't last very long. So a very, very important thing. And next slide. One of the things I'll kind of combine here is that we also have these little fentanyl strips that are under $1, just a little over 50 cents. That one of the things that happened is people started studying this and saying, well, what if we give somebody that uses heroin an opportunity to test their stuff, and if it's positive for fentanyl, it gives them an option to not use. Would they make the decision to not use? And a lot of folks that were cynical about it thought, no, they don't, because they're addicted and they don't care and there's no self-care. Not the case. Right? Lots of folks chose to hold off, not die. They respected the situation. And though they still engaged in the heroin use, it did cause a pause. And that always is an opportunity for us as folks that are involved in the treatment of substance use to engage with them in any capacity. So these are being passed out. This is a harm reduction type of approach. And it should be something that, really anyone that is using illicit substances for opioids and others, really, because you can even use them for the meth, to test and to give them the opportunity to do that. I think somebody asked as well about drug testing. It depends on the panel you bought, right? So you can get a 5-panel cup, or you can get a 14-panel cup. So there's different chemicals and classes of chemicals that are being tested. It's a little bit of a complicated area. So when you see an average cup that says OPI, opiate, remember I made the distinction between an opiate and an opioid. So that won't catch opioids. You would actually, if you wanted to catch oxycodone, you wouldn't get it. You would have to have another little strip there that said oxycodone. And fentanyl is a synthetic opioid, so you would have to check specifically for that. And of course, there is a difference between presumptive testing, which is a little pre in a cup type of things you do at the point of care, and then what are called confirmation testing, where you send it to the lab. Well, sometimes when things don't make sense, that one will always catch fentanyl. Okay, but it is not the same. You have to make sure that in your cup that you buy, you have control over that, that it does have a fentanyl there as one of the strips, and they're also not 100% either. Okay, there's some error of false positives and false negatives. So next slide. I think that might be. Okay, so let me kind of, oh yeah, so look, one of the things that I mentioned as well about stigma and it killing kind of fits into this, right? Why is it that fentanyl strips, if we know they work, if we know that buprenorphine works, if we know that, let's go back to some of the other areas, needle exchanges and, safe injection sites and so many other areas. If we know these things work, why can't we use them more? Why aren't they more available? And a lot of that has to do with stigma. There's stigma all around. Stigma prevents people from seeking care. It prevents people from reaching out. It also prevents sometimes our own ideologies about certain things. And this includes doctors and nurses and therapists and psychiatrists, and then general folks that are out there. We all have opinions about this: legal, not legal, sinning, not sinning, criminal action, lazy. People ascribe so many things to addiction, right? That are they're harmful because it's not looked at through the lens of the medical model, which just says it's a disease like any other disease. It has its properties. They tend to repeat themselves. And so if we did do that, we should be fighting for some of those things to give access to care for folks. So look, we crossed a lot of little dimensions: political, historical. We talked a little bit about some of the medicine aspects of it. We talked about some of the harm reduction and the evidence-based things that are out there. We can go on for days. I'm going to stop here and give it over to Deidre to take over, and then be certainly available for questions after.
Thank you, Dr. Mario. So he is always a wealth of knowledge, and I hope you learned a lot. So I'm going to take it into, now that you've learned everything, how do you apply it into someone's world, right? Their real world, and what are those levels of care that look like? What is there to support them and help them during this time? And then what if they don't want help, right? Not everybody who has an addiction wants help for their addiction. And so what does that look like? So starting with, we talked about how withdrawal management and how people will go out and use a substance because the withdrawal is so terrible. And so a big proponent of that is getting detox for withdrawal management to help you through that process so that you don't turn to utilizing the illicit substances, or if you are already using them, that you're not putting yourself at further risk for overdose. And those can look different. So a detox or detoxification is not treatment. That's the first step. That's getting you off of that substance. That's making sure you're safe and that you don't overdose or pass away, die related to the substances you're using. Treatment starts in the formulation during your detoxification, where we start to talk about what does that level of care look like when you get out of your detox program, and you can start at different levels. So we saw that only 11% of people get treatment, and it's because often people don't know how to access the treatment. They don't know what resources are out there for them, and they don't know who to turn to get the information, right? Either the family has been there, done that, and the family doesn't want to engage, or the client continues to relapse. And so maybe the treatment team or the support team that they've had in the past have burned a lot of bridges with other treatment facilities, or someone doesn't want to have them back because of the substance they're using. And so it can be a really dynamic process. And that's when, a really good case manager, when they're in that hospital setting, can help facilitate that plan. And so there's outpatient level of care, which is just you live where you're living in your own home, or a sober living, and you attend an outpatient program. It can be 3 days a week, 5 days a week, morning and afternoon, depending. But then we also have outpatient or like intensive IOP, which is 5 days a week, and it's either the morning or the afternoon. And then you have PHP, which is partial hospitalization program, which was 5 days a week, sometimes 6, depending on if they have you go to meetings on the weekends. And that's all programming. And so those are the ones where you would live remotely. So you would live in a sober living or with yourself in your own home. Then they have residential, where the programming is included. So you live in the housing containment of the treatment facility, and you get your programming and your treatment while you're there. And they vary in length of stay. Some are 30 days, some are 60 days, and some are 90 days. I like 90 days personally. I think it takes more than 30 days to make real change and to get those coping mechanisms and building up your recovery capital to build you into the next step and getting back into your community and reintegrating. And then sometimes, depending on substances that people are using in conjunction with the opioid or the opiate, it does require hospital or inpatient stays for a longer period of time because of, let's say it's an opiate and a benzo, or we have opiates and alcohol. And so alcohol requires a different level of treatment for an extended period of time. And so we have to look at what else is going on. So within that, it may not only be the opiate, it may be any other polysubstance, which means more than one substance, or it could be mental health. So what is that comorbidity, mental health or medical, that we have to make sure that the placement is correct for you to treat the addiction, but also to treat that comorbidity. And then within that, if the plan is for someone to go on a medication-assisted treatment or MAT medications, then does that treatment facility that you want to make that next step of level of care change to, are they accepting of MAT treatment? Do they have somebody? Because some are abstinence only, which means no substances. And so they see MAT treatment as not abstinence. And so they don't accept that into their programs. And so having those types of questions, it's where the families play a really big role, or the loved ones, whoever's really standing around, wrapping their arms around this client or patient at the time, to know the dynamic of what we're walking into so that you get the right level of care and you don't put a failed treatment because they didn't fall into the right hands. So taking that time to make sure you have all your I's dotted and your T's crossed when you're coming up with those decisions for treatment is really going to be a game changer, because you want treatment to be successful, not just affordable. So it has to fit for the client and the client's needs, and it has to be able to treat the client where the client is at and not what you're hoping to get for the client. I feel like at any time it's a good time to get treatment. As soon as you start to realize that you're starting to misuse a substance, you don't have to be fully addicted to it, but when you start to misuse it, and maybe a family notices it first, it's the best that they bring it up to the physician, or they encourage the client or family loved one to bring it up to the physician that they seem to be using or running out of their prescriptions before they're supposed to. Or, maybe they're run out of their prescription and now they're going to buy it on the street because they can't get another prescription. Or you see that they're getting more doctors, prescribing physicians that are writing different orders for them to meet their needs. So always knowing that you don't have to wait till they're actually addicted to the medication or the substance to get help. But number one, the person, the individual, has to be willing to get it. So whether that's them talking to the physician at step one during misuse, or really being honest when their body becomes dependent on it and they're having really bad withdrawal and they have to be on the substance in order to maintain the withdrawal or not have the withdrawal, prevent it, or when it is impacting their life. Maybe they're not seeing so much of the negative impact, but the family is telling them that there is an impact, but you have to have the buy-in of your client. If you don't have the buy-in of your person, then you get an intervention and then you try to get the buy-in of your person and you see where you can go from there, because that's where the family needs to come together. And that's where that family, the loved ones, anybody that you have surrounding you and the patient or client, to put them together and say, this is what we think you need. And you have a professional there with you that says, here's my professional opinion, you need treatment. And, or, you and some other family members need treatment. But it's really getting down to, are they willing and able and you are going to do it and walk with them, or do they need some further assistance in getting them ready to step into the doors of treatment? Sometimes what really helps with somebody is giving them rewards for their positive behaviors, right? So I know a lot, money is attached to a lot of things. So within our Hired Powers monitoring program, we have these young adolescents, young adults who sobriety is attached to money, cars, insurance, right? So having a tangible reward system sometimes can be motivating for certain people, and that's called contingency management. And we just work through, what does that look like? We don't always want it to be tied to that, but sometimes you have to get their engagement, and that's the first step in getting the engagement, is to attach it to something that they get to gain from sobriety or from abstinence, as defined by what you're defining abstinence as. And then community. So once we get them back and we have them out of treatment and they're ours now to keep sober, how do we do that? So one, we want to make sure they're connected with their community. And that's not just their sober community or their mental health community. That is, are they good at, driving past the 7-Eleven where they used to pick up their drugs and not picking up the drugs? Or do we have to reroute? What's in their community that is going to either help them or harm them? And you have to be able to work through that. And so that's another piece of where you may need to bring somebody in who can help them navigate, hey, how do I get through? I have to drive on my way to work every day. I have to drive through this 7-Eleven that is the most triggering 7-Eleven for me, and I don't have a different route. So you have somebody help them. Let's help determine a new route, or how do we get past that 7-Eleven being a trigger, right? And so that is where you can also bring in all of the mutual support groups like AA. So you have 12-step, you have smart recovery, you have faith-based recovery. So we're not here to dictate what your recovery pathway is or what their recovery pathway is. We're there to walk with them during their recovery path, but we want to make sure that they are connected to their community within that sober realm, as well as their daily community of activities and what they're around and they're going to be around. Also encouraging families to get help, right? Al-Anon, Alateen, all the different support groups, SAMHSA, NAMI, all these different support groups that are out there that help the family, because families aren't experts in addiction and what to do with their family members who are maybe already overdosed and in the hospital, or had a suicide attempt, overdose in the hospital. And what's that next step look like? And they often are very lost and they don't know how to get the help. And so having some type of resource for them can be very empowering for them and make them feel like they have two legs to stand on when making decisions. And they have a support team around them as well to make sure that they're not enabling their loved one, but that they're there to support and guide them through their process while still taking care of themselves. And then within the different treatment modalities, we have so many different things that people can go into, but CBT, which is cognitive behavioral therapy, helps them focus on their self-control and helps them look at coping mechanisms. And coping mechanisms is a word that gets thrown around a lot, right? Kids need coping mechanisms. Everybody needs to cope with stuff. So it helps them develop identifying what are some of my triggers? What are some of the negative consequences? What are some positive consequences? And how do I put that together? So if I am triggered, or I do have to go to a wedding or a work event out of the country where I really want to use this substance because that's what I'm used to doing, what can I do instead? So that helps set up like a foundation for them to allow them to have some other options instead of what they want to turn to related to the substance. Then that also plays into the role of like their therapy. So if they're on medication-assisted treatment and they're doing CBT and they're seeing their physician, that is the treatment, that is treatment. That's what you want in a whole encompassing piece, because That's how they're going to learn to change their behaviors. They're not going to learn to change their behaviors with medication. They're not going to learn to change their behaviors with just through a support group. So it's that foundation, that trifecta of having every piece put together to help them support themselves during their transition to sobriety. And then family members, it's so important to carry Narcan. So I know Dr. Mario spoke about Narcan. If your loved one, or like he said, if even your grandma has an opiate or in the house, having and knowing how to use Narcan is very important. It's a life-saving device. I would never say don't use a life-saving device. If you have insulin for your diabetic, you're not going to give it to them because you're going to teach them a lesson, because they just keep eating sugar and they shouldn't eat sugar. Same thing. You're not going to try to teach your person a lesson by not giving them Narcan. So you don't have to be trained in how to give Narcan. They do come with instructions, but I would recommend you read them before you ever have to give Narcan. But you can, and it's empowering to know that you know how to give it. So there are little trainings for families, loved ones, bystanders that you can watch, but it's really important to know that step one is always call 911. Always call 911, because you're not emergency services. You're just giving a medication that's going to help reverse their overdose, but they're still going to need emergency services afterwards. And more than likely, after you administer their nasal Narcan, they're not going to wake up very happy, because you've just reversed and put them into withdrawal, and now they're not going to be a happy camper. So staying with them, keeping them safe, and making sure if they don't really come to it and they don't come up, lay them on their side, have them relax, but don't try to like make them puke it up. Don't try to do anything. Just keep them comfortable until emergency services arrive. But it can be the difference of saving your loved one's life and losing your loved one. So I always recommend having it or knowing how to use it. And then you are protected. Dr. Murray wanted me to mention this. You are protected with the Good Samaritan law, which means you can't be held liable for not helping, but you also can't have criminal charges filed against you if you do help and the person doesn't want help. And so wanted to mention that piece as well, because I think it's a reason why people stopped giving CPR to people on the sides of the roads and stopped helping people. This law protects you and lets you help people without having any liability for that person. And then last, it's never too early, but it can be too late. So if your loved one, you have questions, you're lost on what the next steps are, reach out for help. If you don't know who to reach out to, you can call Hired Power. We always will give you referrals, whether we're the right referral for you at that time or not, we'll give you a referral to the right place. But also call the physician that's prescribing the opioids, or if it's the opiates, find out how they're getting them and work through what that looks like, because it's easier and better to have the hard conversation than it is to lose your loved one. And with fentanyl and other synthetic opioids and opiates, you're going to lose your loved one. And that's a way harder conversation to have with somebody than the upfront, we need to talk. And that's all I have.
Great. That was so much amazing information. Thank you so much. I know we're going a little long, you guys, but I want to get to a couple questions and answers. We already have some great questions in, and Dr. Mario has already been answering some of them without needing me, the moderator. But thank you, Dr. Mario. So at this time, any other questions, please use the Q&A feature if possible. So, all right, let's get to a few if we can. Does medical treatment reduce the impact of an overdose?
That's a great question. So we can really think of it in terms of what stage of the process of somebody having an overdose, right? There's the pre-part, which means, for example, if somebody is taking a medication called Vivitrol, which is naltrexone, it's the sister of naloxone, Narcan, which Deidre just touched on. It's the kind that's active either by oral means or by an injection that lasts a full month. You just get one injection, it lasts a full month, and it's a blocker. It's not a narcotic in any way. It's just, it acts as a blocker. It sits on the opioid receptor and it doesn't let anything else get on it. So if you were to use heroin, if you were to use oxy, it blocks the effects. So from the standpoint of the early part, does it reduce? Yeah, it reduces. It can block the entire overdose from the beginning. Now, is it 100%? It is not 100%. Humans are known to be crafty. I've had some adolescent folks who, they're just looking for what to test. And they're just saying, well, what if I keep taking more and more oxy? What if I keep taking more and more of this? Yeah, if you increase your dose by 10 times than what you were used to before, there will be a point where you overcome the blockage, the competitive blocking that happens at the receptor level, and you will have a negative effect, though it will still be tempered, right? It'll still be blocked in part. So that question is kind of like, well, it depends on which part you're talking about. And then a medical therapy, besides just blocking the overdose from the beginning, there's the part that Deidre just mentioned, which is the overdose happened. Now, how do you get the opioid off of the receptor so it stops giving its effect, in which case the Narcan does that. And then, yes, absolutely, that works as well. So even in the case of Suboxone, which is buprenorphine, the active ingredient, it has what we call a high affinity for the opioid receptor. In other words, it holds on to the receptor really, really tight. So when you're on that medicine, even though it's a version of an opioid, it's what we call a partial agonist. It's a version of it. It's kind of like one, right? It's a type of one. It holds on to it so strong that even if you were to use something like heroin, let's say, or take oxy, it doesn't bump it off of the receptor. So it acts as a blocker too, in a way, right? You can't. So is it 100%? It is not 100%, though. Probably I can't say anything. I can always keep qualifying that, right? But it does help. They are very effective, and it's not an opinion of my opinion. It's already been proven actually by multiple studies around the world.
Great. I love that. All right. Lots more questions are coming in. So here's a specific, but a great one. What is the best way to treat a patient in the hospital who, for example, uses fentanyl 2 milligrams daily and is now hospitalized after an MVA and has acute pain?
It's a great question. I mean, really, you're crossing over. Well, what if you have addiction, but you have a co-occurring condition called pain, right? And the pain can be either acute or it can be chronic, right? So we can say that this pain that might be acute at the time. Let me give you the short answer. Even people that have addictions and opioid use disorders deserve to be pain-free. So if you're a mom and you're pregnant and you're about to give birth and you've been on Suboxone during this time, on buprenorphine, because you had prior to getting pregnant, you had a heroin use disorder, but you're usually maintained on it to avoid complications of withdrawal to the baby, you still deserve to get an epidural. You don't just say, well, you're already on an opioid. So the correct way is we have to adjust the dose. The doctors will know how to do that if they're worth their degree, and they know how to adjust over the tolerance of the individual on the opioid, and you help them in the acute phase. What you don't do is you don't give them 5 months worth of OxyContin to walk out with. Okay. And then, and if they have a pre-existing opioid use disorder, you engage the case manager, you've engaged possibly the therapist or a psychiatrist in the hospital. You've engaged, if there's any sort of a history of treatment, whatever their treatment community is, so that they have a clear understanding. We're going to control your pain now, and then we need to find non-narcotic ways to control your pain for afterwards. Let's work together to find out what you value. You want yoga? We could do something different. It's just not going to probably be an oxycodone, but you do deserve to be pain-free too, right?
Yeah, I think you bring up a really good point. I've definitely heard about women trying to go without an epidural or without pain meds because they're worried about that. And you're right.
Well, it's how we marginalize people with addictions. That is another reason why there's the stigma. That comes rooted from a stigma. It is kind of like saying, you did this to yourself, you get to pay the price, you get what you deserve, right? Which is completely the wrong way to go about it, not only from a humanitarian standpoint, but guess what? Science has proven that it doesn't work. If it worked, we might have an argument to say, hey, maybe we need to be unethical once in a while to make something work. But it didn't work. We've done it. We've done that kind of a harsh kind of therapy where people are combining. You're telling people, hey, who cares that you got raped 3 times and you have traumas? So and so did this or that. We've had that confrontational thing. It doesn't work. So everyone's an individual. A lot of folks come in with traumas and coping mechanisms that are not very good. And we have to be able to, and you know what, people with opioid, here's another point around that same question. People with pre-existing opioid use disorders have what we call neural adaptations, which means their nervous system gets wired differently. Physically, the receptors change. Proteins go up regulate, some down regulate. There's actual physical, I could take pictures of it, guys. Okay. And then we have the functional MRIs and the SPECT scans that could take pictures of it now. And that makes them actually process pain differently. Where the stigma still pushes to people not believing them. They're thinking they must be drug seeking. Let me use that in air quotes, because I hate the term, right? It means we're judging them for communicating they're having a pain because we're assuming they're doing something, they're lying and things like that. Now, do people lie? People lie. Guess what? My 70-year-old Medicare patient on her blood pressure medicines who doesn't have addictions tells me she takes her medications every day. She probably takes them 3 times a week because I know her blood pressure's off. She's lying to me too. It's called the human state. All right. We don't need to include it into the addiction part. Although we do know there are aberrant behaviors, and that's why we have certain things. The relationship with the person is the most important thing.
That's really great. Okay. I know we've hit the mark, but this is being recorded if anyone has to go. Otherwise, if it's okay, let's get through a couple more questions. So this is a really important one. 2 questions around the similar topic. But what can I do to help with this as an education professional? And someone else said, what can we do from the standpoint of harm reduction?
Deidre, you want to take this question?
Yeah, so from an education perspective, depends on what kind of education you provide. Are you a teacher or are you like a nurse educator? Really, everyone should be educated. So taking your knowledge and sharing it with people is going to be empowering. So if you're in the field of, in a hospital and you're a nurse educator for any type of unit, it doesn't matter, because most of the time we're not only going to see them on our addiction units, or the hospital doesn't even have an addiction unit. So these patients are within all of your units, your ICUs, right? Chronic pain, fentanyl. So your ICUs, your medical floors for a motor vehicle accident or any of those types of things, they're not all going to be pointed out and defined as an addict. So knowing and being able to provide that education to nurses who don't know what to look for or how to help is always going to be empowering. If you're not in the nursing field and you're in the field of maybe just working in schools, it's very important, I think, if you are educating parents. So if you are someone who sits and works in the education realm with the parenting and is seeing maybe the troubled kids, or is in the school nurse's office and working with a psychologist or any of that type of stuff, education is power. What parents don't know, they can't help with, and they don't know how to always get these resources. And so educating the parents is going to be huge, because what is more empowering for a parent is to have the knowledge around what to look for and how to help and what to do, because it's a helpless, hopeless types of feelings if you don't know where to go to. What was that, the second part?
What can we do with harm reduction from the standpoint of harm reduction?
So Dr. Mario touched really nicely on harm reduction. One, around your fentanyl strips and testing. It's not enabling them to use the fentanyl, to use the drugs. They're at least trying to take a step in the right direction to not use fentanyl, but also with MAT treatment, medication-assisted treatment. So for those people who just cannot, the chronic pain is there, or they can't stay off the substance, looking at how do you integrate that with treatment, and how you just have to be, you really have to want it and you have to stick with it, because medication-assisted treatment is not a one and done. You don't just get your prescription and you run on your way and you call it a day. There are pieces to that you have to follow. And so those are huge harm reduction platforms. Knowing what's in your drugs, number one. And if you can't control that, then how do you look at treatment and medication-assisted treatment?
And,
Great.
you know, and Deidre just answered the question that I thought was so important that Felipe brought up. Look, this is why education is so important. It's so that we get past, you know, what is enabling? Is enabling keeping your daughter alive? Well, if that's enabling, I'm all for it. Okay, my hand is raised. And so that is not enabling. That is not what we mean in the context of what enabling is, which is a much more enmeshed type of process of kind of permissive, adding to aberrant behaviors through other means. But you're right, and this is for every parent, everyone that loves somebody. You can't control them no matter what. I mean, there's no way to do that. But you can love them and support them. And it doesn't mean agreeing with them. And it doesn't mean giving them the means to go kill themselves either, right? However, giving them the means to make better choices, like giving them a fentanyl strip or access to fentanyl strips to help them make better choices, that means that there's one more day of potential engagement where you can show her how much you love her, how much she means to your family, and that there could be somebody she resonates with or something she reads, something that makes sense to her at some point that gives her one more chance to move forward and then to continue and be there the next day. Whereas the other way is kind of like, well, you're on your own. And I think that's a lot of parents struggle with that, not only from the standpoint of strips of fentanyl, but strips of Suboxone too. The idea of medication assisted treatment. Well, aren't they switching one drug for another? Okay, no, they're not switching one drug for another. It's a whole nother talk. The chemicals are completely different, what they cause. You don't get high off of it. And then it has all these special properties that do make people safer. And then science is clear. This group lives and this group doesn't. And then let's look between the living and dying. Between the living and dying, you can argue that there's more tragedy. And the reason is because you get to die of 1,000 lashes. And that person dies of not just there's mortality, which is when somebody dies, but there's also morbidity. It's, I lost my wife. I lost my child. I lost my job. I lost my self-worth. I lost my self-identity. I hurt somebody I never would have loved. I never would have hurt. I hurt myself. There's so many, though. Those are the 1,000 lashes that addiction does to people. So you know what? It's not just dying and living. It's quality of life. And so when I sit in front of my patients and their families, and we discuss the idea of what is quality of life, I just say, quality of life is, are you in a state to love and be loved? And forget all the receptor goobly goob glop that I kind of nerd out on, right? Because that's not the important part. So that's really the emphasis. So Felipe, it's the right way to go. Thank you for the question.
Amazon.
And you can get them on Amazon.
It's where you can buy them.
Easy.
But I'm sure you can buy them at the stores too. But Amazon is the best place.
Well, that was a beautiful note to end on. Thank you for everyone that stayed till the end. Everyone else who's watching this later, if you had to leave, I hope the recording is helpful. Please, education is the most important. So we're gonna send out the recording this weekend, and I really encourage you guys to forward this to any professionals, loved ones, anyone that you think might be able to be, helped by any of this information. And Hired Power is, of course, available for any needs. We are available 24/7. You can call anytime on our website. You can schedule a meeting on the website if that's easier. Our phone number is 800-910-9299. Again, it's 800-910-9299. Or you can go to hiredpower.com and you can send us a message or set up a meeting right away. And like Deidre said, most all treatment professionals should meet you where you are. So don't worry about wherever you are in your journey, where you or your loved ones. Hopefully there's a way that we can provide some resources if we're not even able to help, or we can help. So thank you so much to our amazing speakers, Deidre and Dr. Mario. So much important information you shared, really some touching words as well. So I really hope that this can help others and, to spread more education in the world to hopefully help everyone with their better quality of life.
Yes.
Thank you, everybody.
Thank you so much. And I hope to see you all again soon. Bye.
Bye.